Good afternoon, everybody. It's a pleasure to present on our approach to tremor radiosurgery at UAB. And I want to acknowledge the whole team first at UAB, including our medical physics team, our neurologists, and our surgeons. So this is a team effort, and I'm presenting on behalf of the whole group, the data here, and of course, radiology as well. So the objectives of the talk today are to share our insights on edge-based tremor radiosurgery, and then present data on the clinical trial that we have been running for the past about 6 to 7 years at UAB with patients with essential tremors and tremor-dominant Parkinson's disease, and the outcomes as well. So tremor is a pretty common disease. There's many subtypes. The most two common ones are essential tremor, which is the by far most prevalent one. And the second most frequent one is tremor-dominant Parkinson's disease. You can see on the slide that as patients age, the incidence increases with an estimated prevalence of about 5 to 6% in patients who are older than 60 or 65 years. It most often affects the extremities. Very often with essential tremors, it's bilateral. It's actually the definition of essential tremors that you have bilateral disease. But in many patients, there's also the midline tremor that affects the head, the vocal cords, the lips, and the torso. And that's a much more challenging tremor to treat with radiosurgery, but we're going to report on that a little bit as well. And tremor is certainly a benign disease. We're also used to treating cancer, but it still is very disabling and also socially stigmatizing in patients going to restaurants and people think they're drunk. So certainly there's a need for treatment for many of those patients who become medically refractory down the road. So the gold standard of medically refractory tremor is still deep brain stimulation. But there is a sizable number of patients who just have medical contraindications, or they're just not candidates for DBS. And certainly there's a quite large number of patients who also just don't want to have DBS because of the invasiveness, the need for undergoing still most often an awake procedure with wires being implanted in the brain and then battery packs that they carry on the chest. So those are the patients who are potentially candidates for radiosurgical thalamotomy, and those are the patients who are being referred to us by the movement disorder neurologists and then vetted for radiosurgery, and then we send them on to our functional neurosurgery colleagues, and as a team of effort, we'll treat those patients as a team. So those are kind of, once a patient becomes medically refractory, which happens in most cases at some point, there's DBS, which is frame-based or frameless, which is, again, the standard of care. But then there's a renaissance of ablative therapies now as well, and certainly most data in terms of radiosurgery have been generated on the gamma knife, foremost Dr. Regis and colleagues. But then the newer kid on the block is the focused ultrasound, which now for several years has been FDA approved modality that I think shows efficiency, although there is concerns with some of the acute side effects. I'm going to show this in the next slide, and the sustainability of the lesions that are being set with this device. So this is just a quick, you see on the right lower image, there is a need for a frame for those patients. They need to be mobilized. They will be in that frame with ice-cold water around the head for an extended period of time. Usually the procedure takes 2 to 4 hours in the hands of a very experienced team like Dr. Lozano. It's more like 2 hours, but still it's frame-based, so you can claim that it is not invasive. There's discomfort, there's often pain involved with, a heating of the bone marrow in the skull through the microwaves, which can be quite severe in a subset of patients. And then many of the patients will leave the table, although they have an immediate effect on the tremor being better, that they will have some form of side effects, most often balance issues, which are sometimes temporary, or numbness. And we're going to look at Dr. Eliza's trial down the road with the adverse events a little bit more. So that means that there certainly is room for improvement, and radiosurgery certainly has certain advantages, especially in terms of the sustainability of the lesions that we cause. So what should a ideal functional radiosurgery procedure look like? It should have maximal patient convenience and comfort. It should be truly non-invasive, not involve a frame, should be quick, robust, and the delivery should be reliable, of course. So we're treating our patients at UAB on a modern edge. Again, we're not using a frame, we're just using the Encompass mask as the immobilization device. We're using the little bite block that comes with the mask for this indication. Usually for our brain mets, we don't use the bite block. And we monitor the patients real time with the Identify optical surface monitoring system. The treatment is fast and precise. It takes, with the 10x FFF beam, if we don't have to realign, about 29 minutes. With the 6x beam, which we now commission because the penumbra looks a little better, treatment is somewhat longer, about 39 minutes, based on the calculations that we have from some of the patients that we've done on the 6x now. So traditionally on a LINAC, usually physical cones have been used to shape the dose. And that's fair game, that's totally fine, but there's certain shortcomings that come with those cones. There were safety concerns, in the past, which some of you will know have led to misadministrations that made it to the New York Times. It just doesn't lend itself for integration to a clinical workflow on a busy edge where you treat 60 or 20 patients per day, because you have to mount that cone, you have to do physical QA before you treat the patient, you have to take off the cone, you have to again adjust the machine, and so this will evolve into a 3-4 hour ordeal while you cannot treat your cancer patients with that device. It requires a specialized dose calculation system, it's time consuming, and the patient-specific QA is certainly, of course, required for those applications. Because of that, in the around 2015, Dr. Richard Poppel, who is our vice chair of medical physics at UAB, has invented the so-called virtual cone. It is a predefined MLC control point sequence that delivers or generates a perfectly spherical 4.5 to 5 millimeter dose distribution. And we're going to look at the next slide how this works. We're using a standard Accurate dose calculation algorithm with this, and the geometric QA can be done on a much more flexible schedule. So we're not really doing patient-specific QA on those patients because it's a predefined control point sequence. And if you look at the beam profile in that lower right image there, this is the 4 and 5 millimeter physical cones versus the virtual cone. You can see that the beam profile looks almost identical. And so how does this work? So on the high definition MLC on the edge, we'll use the two center MLCs, which are 2.5 millimeters wide. We're going to open those up by 2.1 millimeters, which generates that rectangle that you see on the lower left in the middle image there. And then we arc around the patient in 5 predefined couch positions, and that generates that perfect spherical dose distribution. We're using full coplanar arcs and then 4 couch positions with a couch angle, and those are half arcs, and for a total of 20 arcs. The dose rate is proportional to the sine of the gantry angle, and the 10x beam goes up to 2,400 monitoring units. So we've treated patients with this technique off trial, about 30 at this point, and on trial I will only report on the trial patients today, which are about 40 patients. And so we're having now follow-up of 36 months on virtually all those patients. So this is kind of one of the first outcome reports of this trial. So the trial was named RAD1601 and was sponsored by Varian. It enrolled 40 patients with essential tremor or tremor-dominant Parkinson's disease. We're delivering 135 gray in a single shot using the virtual cone. We're imaging the patients before the procedure and then longitudinally with all these time points that you see listed down here for a more longitudinal assessment to see what happens basically with the patients after we do the procedure on a functional resting state fMRI level, but also in terms of tetrography. And then patients are being assessed at all these milestones for toxicity using different tremor rating scales, foremost the FDM, but also the TETRA scale, and then quality of life and patient satisfaction. And again, those are all patients who are vetted extensively by the movement disorder neurologists, and they set the indication for this, and they tell us this patient is medically refractory. That patient, of course, all those patients were counseled for DBS, And I would say in that cohort, about 50% of the patients, probably even more, did not want DBS, and about 50% just had medical contraindications, being on blood thinners or having other comorbidities. So in terms of the targeting, we started off doing this based on standard stereotactic coordinates. I think that many of the centers just use. You see those kind of referenced on the left side. The target of this procedure is the ventral intermediate nucleus, which is in the ventral thalamus. You cannot see that nucleus on standard MRI imaging. Some groups have claimed maybe on an SW on a 70 you can see it, but in reality you can't really see it. So it's a blind target. So what we do is that we now adjust these stereotactic targets for a structure which is that we see on a white metanol sequence, which is the correlate of the dentatorubothalamic tract, the DRTT, which is kind of the tract which is thought to being the correlate or the target for these trauma treatments. The planning, and so we force the target into the apex of what we call the rubal wing. It's on the next slide. But once we have the markers set, once we have the contours done, then Dr. Popple will go into the planning phase, and it really it takes about 2 minutes to generate the virtual cone plan. This is again kind of this F-gate hypointensity. They're also called the rubal wing, which kind of originates in the red nucleus and goes through what is called the prelimniscal radiation into the subthalamus and thalamus, which is the imaging correlate of the DRTT. So this is overlaying one of those virtual cone plans on the F-gate sequence, and it's probably not very visible. Just believe me, the green line is the area of ablation, so that's the 4.5 to 5 millimeter diameter volume. That's where we deliver at least 67.5 gray for the patients. And that's kind of the size that in most patients will correspond to the lesion that will then evolve over the next year or so. So this is an early lesion after 10 weeks. You see it's still fairly small. It's just evolving. That's the first MRI that this patient had. So down the road, it will grow bigger at some point, hopefully stop growing. Otherwise, it's deemed a hyperresponse, which we see in about 5 to 7.5% of the patients. And you see how the radiosurgery plan is overlaid, and the target fits essentially, or what you can see as the target or at the area of ablation fits perfectly into the location of that radiosurgery plan. Dr. Popple has a poster at this meeting, and I don't want to take away from that, where he reports on the accuracy of this treatment. And you see the graphs in the bottom. I'm not going to go into detail because it's really on his poster, but in a nutshell, what we find is that the accuracy of the treatment is up to par with a frame-based gamma knife treatment. So this is an example of an 86-year-old patient with the postural trauma that you see. We targeted the right arm. Left is pre, right is post, and you can see how the tremor is greatly improved and how the spiral drawing for her became certainly much more easier, and the writing is very legible now. So an example of a typical successful radiosurgical thalamotomy. So and this is kind of what I mentioned. The lesions usually evolve over time. We get the first MRI usually at 3 months. It doesn't make really sense to image the patients earlier than that. And then we keep continuing to kind of monitor up to 36 months with many patients who are going to 5 or 6 years now. But you see how the lesion evolves and becomes more preeminent. And then at some point, and that's usually around 12 to 18 months, 95% of the lesions will stop growing and just exist. So this is the outcome analysis for overall tremor response in the 40 patients. This is based on the FTM scale. So this is kind of an assessment, a tool that assesses the tremor throughout the whole body, not just for the extremity that we treated. So it includes the tremor in the midline, the contralateral arm as well. But you can see how the tremors, the scores dip down. On average, we're seeing about a 55% reduction in the tremor scores at 12 months, which in this trial was significant. I think more informative probably is this rendering here, where we break down the FTM scores into the treated side, which is contralateral, the untreated side, which is ipsilateral, and the midline. And what we see is that the tremor scores keep declining over time, even after 18 to 24 months, we're seeing still a great tremor response in those patients, indicating that the sustainability of the lesions is excellent and the patients have sustained tremor response. The ipsilateral side is negative, not significant. That's kind of the control. That's what basically you want to see. In some patients, those scores will actually go up as the tremor progresses systemically. One finding out of the trial that was interesting or unexpected to us is that we also had an effect on the midline. So patients with voice or neck and head tremors, about 50% of those patients, probably 60%, had some improvement in the midline tremors as well. And that's really not the target of the treatment. Usually for DBS, you do bilateral procedures on both sides to target the midline. But we think that our targeting with the radiosurgery is a little more medial in the thalamus than the DBS. And we're capturing probably a portion of the non-decussating portion of the DRTT, and that might explain more, seeing some effect on the midline here as well. So that was a very welcome and surprising effect for our patients. So this is, shows you again, kind of in these estimates, the onset of the tremor response. So in this trial, the median time to response was 4.1 months. I think that's kind of up to par or kind of similar what most studies shows. 3 to 4 months is as an average what I tell my patients, but I tell them also you might have to be patient and wait much longer, sometimes 18 months. And you can see on this slide that there is even late responses as up to 24 months for a good tremor response. This is the midline improvement. Again, not as frequent, of course, about 60 at the end, 65% in the trial. And it took a little bit longer for that response to set in, about 6.3 months as a median in this population. So I want to kind of show this slide, but be careful about this because it is not a 100% fair comparison because those are different trials with different designs. But I think the bottom line message is, and this is Dr. Elias's landmark trial in New England Journal of Medicine for the focused ultrasound, which essentially led to the approval of the focused ultrasound by the FDA. But you can see based on his scores that you get a maximal response around 3 months, and then the tremor scores start kind of creeping back up. So the time that you have the effect for the patient is not as extended as for the radiosurgeries. I think it's just reflection of the fact that those lesions with the focused ultrasound are being set instantaneously, and then they just resolve much quicker than the radiation-induced lesions. There's an example on the right side. One of the patients, she was a pencil artist, and she had a delayed response actually at 18 months, and but you can see that when she started back drawing without a brace, that she was able to doing those fine pencil colored artwork, and she was very happy with this. Again, the range, so that I tell my patients you have to wait anywhere. The earliest response we've seen was 1 month, the latest around 24 months. So it's very variable, and there's no way for us to predict this up front. So we just tell our patients, if you don't see something at 3-4 months, don't be discouraged. You can still have a response down the road. So these are the adverse events of the trial. Left side is the RAD 1601, and right side is Dr. Elias's focused ultrasound. So some of the patients will develop a neurological symptom, and that is predictable, and we know this from the literature. Those are patients that we know develop what is called a hyperresponse. So they will develop a larger lesion. There might be a little bit of radiation necrosis involved. Those are the patients that we then treat aggressively with steroids, with Avastin, and sometimes with Boswellia serrata as well, and try to counteract the effects. And some of the patients will improve, and so the neurological deficit will be transient. In some patients, the minority, it will persist. And so that's something that we counsel our patients about very carefully, that there is just a small risk that there might be a neurological symptom down the road. But you can see overall 12.5%. It is fairly low compared to the focused ultrasound. If you look at the breakdown of that trial, where at the end you had about 90% adverse event rate for the patients that were enrolled, about 60 patients on that trial. So I would say that this compares fairly favorable. So in terms of targeting, We know that the stereotactic targets are not ideal. We know that there's patient-specific connectivity that we need to take into account. I think it's reflecting the fact that we see a good response. About 80% of the patients, 20% of the patients don't respond as well. And so the question is, what can we do for those patients to increase the efficiency of this procedure? And so we're getting a fairly extensive imaging protocol on those patients, including a 3T prisma. And then for the first 20 patients, we did a 7T as well. We've abandoned that then after 20 patients because we realized all we can do on the 3T as well, which again, in terms of implementing this at other centers, I think is much more straightforward. And so this includes extensive DTI imaging, this includes resting state functional MRI imaging as well. It's about a 1-hour protocol for the patients, and they get this at every milestone from baseline to down the road. So when we map kind of at the functional level, what is the target or the sweet spot for the tremor response? It became very clear that it's really the DRTT and the projections of the DRTT into the motor areas like the M1 and the supplemental motor area and the premotor area cortex. And so if you look at this is the outlines you see based on probabilistic tractography in the thalamus, the M1 region, the S1 region, the SMA, and the PMC. And in orange or yellow, you see kind of the sweet spot of maximal tremor response. So the more yellow it is, the better the response. And so what it shows you basically that the sweet spot on the group level really maps into that M1 to border of SMA, PMC as the ideal target, because that was the question all along. Is the sweet spot for radiosurgery the same as for DBS? Can we assume that what the DBS neurosurgeons do, is that also the perfect target for us? And so if we parcel this into the nuclei, like the VIM nucleus, you see that the sweet spot in red here is kind of right in the VIM nucleus. But I think more importantly, really, in that middle graph, it's the DRTT, so it's the tract that is the target. It's really not the nucleus as much as we thought in the past. And so if we map kind of our radiosurgery sweet spot in comparison to the DBS sweet spots by major centers like Mayo Clinic, including Dr. Middlebrook's work, who, by the way, is the phenomenal neuroradiologist who has done all the wonderful imaging work and processing on these patients, you see that it actually is fairly close, right? So from that analysis, we kind of figured that the radiosurgery target really is similar to the DBS target. So if you do neuromodulation or if you do ablation, it seems that the targets are fairly congruent. And the one thing, and this is busy, I don't want to spend too much time on the slide. The one thing we learned really in terms of the ideal tremor response, the plane that was most important is the Y plane. So if you look at the axial image here in the thalamus, the DRTT, the sweet spot is really right on the DRTT. We had patients that mapped based on the stereotactic coordinates right posterior to that, more into that area, and those patients did not respond as well. So as a result of this analysis, Dr. Poppel's script will now kind of start with the stereotactic coordinates, and I will place kind of the mark at the apex of the rubral wing, and that will force the Y plane, and then Dr. Poppel's script will automatically take that into account so that we don't leave that Y plane to getting the maximum response for the patients. So in conclusion, the virtual cone, we believe, is a new, efficient, and robust technique for radiosurgical thalamotomy on a modern LINAC SD edge. The integration to the treatment planning system, along with optimization of dose calculation, makes this seamless. Patient-specific QA can be done on a much more flexible schedule than with cones. And we're happy to report that as part of this trial and additional data, that the Edge and the TrueBeam platform is now completely 510K cleared for medically refractory essential tremor, not for tremor-done Parkinson's disease, but for essential tremor at a minimum. And again, we feel like that if we integrate the virtual cone with connectomic fingerprints, and there's work in progress kind of integrating those into hopefully what will long-term be a package, that this will be an exciting development to find patient-specific markers for best response in our patients. Thank you very much for your attention.
Thank you, Dr. Yeah, it's great.
Questions later?
So the questions at the end, so we'll have the other two talks, questions at the end, and the next talk will be Dr. Moss, and his presentation should be coming up. There we go. Okay. Perfect.
That was fantastic, Marcus. And Raymond, thank you so much for the kind introduction, and to Varian for having me present today. So switching gears a bit now to the topic of brain metastasis. As you heard, my name is Nelson Moss. I work at Memorial Sloan Kettering in the brain metastasis space. I'll be speaking today about the clinical problem we face in this patient population, the program we've been building in trying to address their needs, with a particular focus on integrating SRS into the neurosurgical workflows. And then I'll be highlighting some aspects of our work trying to move the needle in terms of understanding optimal treatment sequencing paradigms. So I'll start by saying that among most surgical disciplines, among oncologists, neurosurgeons are fairly unique in our focus on brain metastasis, in large part because of the huge symptomatic burden that these lesions impose upon our patients. So it's fairly intuitive that in a case like this, relatively moderate sized tumor that's just deep to Broca's area, exerting a lot of edema on the corticospinal tracts, that a tumor that is only 2.5 or 3 centimeters can actually make a patient aphasic, suffering from severe headaches, nausea, and even severe hemiparesis. So even in a patient with advanced disease, it can often make sense for us to operate, knowing that survival can be limited. And this is a patient where we operated on a patient who was very symptomatic. She went home 2 days later, and she's still alive now 2 years later, essentially ridden of her symptoms. So you can imagine we live in a universe where CNS screening is not routine. We often see larger tumors that we have to operate on, and this is actually a big part of our neurosurgical patient population. So these tumors, as many of you know, affect some 20 to 30% of all patients with advanced cancer, and are a strong majority of the malignant brain tumors that we see. Importantly, they're also the cause of death in 20% of patients with cancer. And this is for two main reasons. One is that patients with symptomatic tumors are less fit for treatment. They suffer complications of their disability, and also because the treatments are less effective in the brain. And so we do rely very heavily on local therapies, most importantly radiosurgery, to try and control these lesions. To the next slide. So here I'll just highlight that survival after brain metastasis diagnosis does hinge very strongly on the cancer type and also the molecular phenotype. And so here we have the main cancer types. You can see that the range of survival ranges from 6 to 48 months for most diseases. And this is using the graded prognostic assessment, which as of a few years ago now includes molecular features. For example, in breast cancer, if you're HER2 positive, if you have lung cancer and you're ALK rearranged or EGFR mutant, your survival can actually be many-fold higher than patients without those. And this is a dramatic difference from just 10 years earlier, where the same previous version of the graded prognostic assessment actually portended a range of survival from 2 to 12 months. So even in just a decade, we've seen significant improvements in survival. All of this together, and all of this together is leading to a very expanded patient population that we're seeing. In this slide, I'll just show some of our invasive toolbox. As a neurosurgeon, I'm obligated to show you some of the cool things we do every day. But our current range of invasive procedures includes microsurgery, stereotactic biopsy. In some cases, we're doing brachytherapy, for example, for salvage after radiosurgical recurrences. In some cases, we do awake resections, like in that case I showed you earlier. This is often informed by neurophysiology and tractography imaging preoperatively. And more recently, we're using laser ablation for selected patients with deep unresectable tumors that need a biopsy. Given that brain metastasis patients are cancer patients, this is maybe the most important slide of this talk, is that all treatment decisions really have to be made within the context of their disease and their needs to be back on systemic cancer therapy, which are literally life-saving for them. And keeping in mind that there are interactions which come up with combining these treatments or sequencing these treatments. So for example, in melanoma patients where immunotherapy is one of the most important backbones of treatment, We have to be very cognizant of the potential interactions between radiation and inflammation, the way that we treat radiation necrosis. I will say that oftentimes in a patient who needs immunotherapy or who might need immunotherapy, we do have a lower bar to operate to try and reduce their edema for that reason. And I will also say that these patients do have advanced disease, so it is also important to recognize that everything we do is palliative. We should really try and reduce invasive procedures where possible. SRS is the backbone. Something like 90% of all of our patients are treated with SRS. Whole brain, as we can discuss later on, is really increasingly out of favor. Here I'll just highlight a little bit of what we've been doing to try and coordinate and integrate all of the different aspects of a patient's care. So at Memorial Sloan Kettering, we have a multidisciplinary brain metastasis program, which we've been building over the last 6 years. And I'll just mention some of the different elements. The linchpin of this whole program is our weekly brain metastasis tumor board, where we discuss all new cases or all complex cases together with neuroradiology, with radiation oncology, neurosurgery, neuro-oncology, particularly for patients with leptomeningeal metastasis or symptomatic edema, and medical oncology. So we have standing representation from the key cancer specialties who are there every week. You can imagine that the expertise changes from week to week, so we do invite every patient's oncologist to be there with us. It's a virtual format, so we can pre-schedule the meetings. People will call in at 9:10, 9:15. We had it just this morning, and they can be present just for their patients. And in fact, this morning we batched 3 or 4 breast cancer patients, and there was a lot of fruitful discussion about medical options within the bigger picture for this morning's patients. And we do invite outside oncologists. So, not every center can harbor all of the different specialties that can be helpful. And so we do invite many providers from, throughout our region who will call in, and they'll ask for a piece of advice on different aspects of a patient's care. We also have a multidisciplinary clinic where we can actually physically provide local therapy opinions at the same time. So radiation oncology will see almost all patients. Neurosurgery will see all patients where we have deemed them surgical candidates. And as part of this, we do pre-schedule it so that the patient's visit is as seamless as possible. As I mentioned before, these are sick patients. They need their cancer treatment. They often have pre-existing deficits. So we really do try and emphasize care coordination. So when a patient comes in to see the radiation oncologist, they will also get their simulation scheduled the same day, have their mass fitting and cone beam CT, or their planning CT all done same day. And then they can go home and get their treatment done just a couple of days later. We also have a long-term follow-up clinic for these patients. For those of you with inpatient services, we also integrate that aspect of it, and we have a triage program for our emergency room. Here I'm just going to share an example of how our service integration has led to better outcomes for our patients. So as many of you know, the standard of care following brain metastasis resection is SRS. And this has been validated by many studies. We know that there's less cognitive disability after SRS over whole brain, and control rates are much better. The biggest studies, as you're probably familiar, have shown control rates on the order of 70 or 80% at 1 year following metastasis resection plus SRS. However, that range has been a little bit disconcerting because some single institution series have shown control rates even higher than that, and others have been stuck at the lower 70% rate. A lot of effort has been done looking into fractionation and dosing. We have asked the question specifically at our center about whether timing actually might make a difference. And we looked retrospectively at 300 patients who were treated at a median of 30 days following treated with SRS, a median of 30 days following surgery, which is what's been reported in the largest pivotal studies in this space. And we simply bifurcated if patients get radiation before 30 days versus radiation after 30 days. And we found, and this has now been validated by 4 or 5 other centers, that radiation delivered within 30 days after surgery has a dramatically lower rate of recurrence at 1 year. And these are not immediate recurrences that happen in that first month. These are recurrences that happen, 3, 6, 12 months later. As a result, we've actually re-engineered our workflows. Whereas patients were having surgery, they would go home, we would make an appointment for them with radiation oncology. The radiation oncologist would often say, we're not even going to see the patient till the staples are out. Then we'll organize their simulation. Radiation wouldn't, and then that's kind of what brought us to our 30 days very easily for these patients. We've started a program basically where instead we're mandating that our high-res MRI scan is done on day 1. That's the one that's used for radiation planning. Sorry, let me put up this next part. We do the simulation in the hospital or very soon thereafter for patients who are convenient to our regional sites. And this way we actually overlap the treatment planning with the recovery period. And that way, the date that staples are removed, they can actually present for radiation treatment start. And this has allowed us to reduce our treatment start time from 4 weeks to 2 weeks. And this had several other add-on effects. For example, we were able to reduce the number of scans that were performed. We reduced the number of visits that patients had. They, since so much was done in the hospital, they actually wouldn't have to come and go, 3 or 4 times to their providers. And patients actually started their systemic treatment sooner after their radiation was completed. We've since been starting to look at how those patients are doing longer term. It turns out that radiation, and really asking the question, is radiation delivered at 2 weeks or 3 weeks as good as radiation delivered less than 30 days? So trying to tease apart, is there an optimal window for radiation start time? It turns out that we're basically equivalent. Everything within 30 days brings us to that control rate of 90-95% at 1 year. We're starting also to look at the signals for adverse radiation events, radiation necrosis. We're not quite powered yet to really tease out the signal for patients who are treated at 0 to 2 weeks versus 2 to 3 versus 3 to 4 weeks. But we have been seeing maybe a slight uptick in postoperative enhancement around the cavity for patients who are treated before 3 weeks. So at the moment, we're kind of happy to have a workflow where patients are treated around the 3-week window. I'm just going to briefly pivot and discuss what I think is a very important space. The data are not yet mature, but in treatment sequencing. At what point do patients get radiation? When should they get their systemic treatment? Does it matter what the treatment is? And all of this work really is in service of cases like this one, which I'm about to show, which we're also hoping to see much more of. So this is a patient with a large and symptomatic posterior fossa tumor, newly presenting with lung cancer with a lung mass. And this patient was scheduled for surgery, but we also knew that there was a small chance she would have EGFR mutant lung cancer, which we know responds magically to EGFR inhibitors. And in fact, this patient was started on osimertinib, which is a 3rd-generation inhibitor. And this patient's tumor melted away. So we got a scan just before scheduled surgery. It did go away. But I also use this case to illustrate that there are still large question marks. So in this patient's case, the response was not durable. At 5 months, the tumor did recur. We have other scans showing it was FDG avid and hyperperfusing and very concerning for recurrent disease, and ultimately was retreated with SRS. SRS was much more durable. Maybe Varian won't be happy if I said that eventually this lesion did recur, which is a very rare occurrence for something of this size. And way down the line, she ended up having surgery with brachytherapy. But this patient is now alive 4 years later, essentially cured of her disease. And it's been a little bit of a journey, but it would be really helpful if we better understood the durability of our medical therapies, even the ones that work this well, and integrating radiation into these patients' paradigm. And so pharmaceutical companies are increasingly recognizing this. There are now more and more studies that are designed specifically with these patients in mind. And now we have some really nice examples of small molecules and immunotherapies and other agents that actually have proven CNS efficacy. And it prides me to say that the community has now really stepped up and started building in CNS-specific endpoints, measuring lesion sizes and kind of really describing what happens in the brain, not just in patients with brain mets, but what happens in the brain. And so we are optimistic that we will have more and more agents that we can now integrate into these patients' care. I'll finally say, just with regard to radiation, this is one important example of integrating radiation with medical therapy. So antibody-drug conjugates, sorry, I'll just briefly mention, may have an increased signal for radiation necrosis when given concurrently with SRS. And so increasingly, if we see a patient that we think needs SRS, we give them SRS sooner, and we'll either keep them on a tyrosine kinase inhibitor or start the ADC later. So just in summary, improving patient outcomes, I think, is really dependent on integrating all of our colleagues and looking at these patients in a multidisciplinary fashion. This collaboration and coordination we really think can make a big difference for these very sick patients. With that, I'll leave you, and thanks very much.
Thank you, Dr. Moss. That was awesome. In the final presentation, Mark Bilski. Dr. Bilski is known for about 17 years. He's a great neurosurgeon. They probably do more spine radiosurgeries at MSK than any other place in the world, thousands of spine radiosurgeries, and it's a great honor to introduce Dr. Bilski. Thank you, Dr. Mark.
Thank you for the invitation, and thank you for allowing me to speak on this. Just a quick show of hands. This is not interactive, but just a quick show of hands. How many people are doing spine radiosurgery? A lot. Oh, that's great. Okay. So I'll show you a little bit of our experience over the last, now really 30 years. We've had an integrated program at Memorial. Metastatic spine tumors are a massive problem, and we've seen an increased number over the past decade or so, partly as an ascertainment issue that MR and FDG PET have improved detection, but also the systemic treatments have improved survival. But the biologics and checkpoint inhibitors are much more effective for visceral than for bone disease, so we think we're going to see a continued uptick in the number of tumors that we're responsible for. And despite this improved survival, the treatment remains palliative. And we get this kind of outcome of this patient doing this 100-mile paddle on this Whitewater River after undergoing separation surgery for an L3 mechanical radiculopathy. We've clearly done our job in palliation versus this patient who has both failed fixation and a radiation recall burn requiring extension of hardware and a free flap reconstruction. Everything we've done in the past 30 years is to mitigate this kind of outcome. From a historical perspective, really up through the late 1980s, there were two treatment options: laminectomy without instrumentation and conventional external beam radiation. Laminectomy without instrumentation was a terrible operation, created iatrogenic instability, deformity, progressive pain, and often neurologic decline. Conventional external beam radiation, often given as 30 gray in 10 fractions. A paper as early as 1978 from Memorial by Gilbert Kim and my great mentor, Jerry Posner, show that solid tumors were what they called unfavorable responders, or what we now call radioresistant. Despite these poor outcomes, conventional radiation was better than decompressive laminectomy and became standard of care. By the 1990s, we had the development of segmental instrumentation, transarterial embolization for hypervascular tumors, and then the Patchell study 2005 showed that surgery was better than conventional external beam radiation for solid tumor malignancy. And we began to see this proliferation of incredibly aggressive morbid approaches for metastatic disease, including en bloc spondylectomy. The decision-making during this period was largely surgically based, including the Tomita and Takahashi scores. By 2010, we had the development, evolution, integration of really transformative technology in the form of stereotactic radiosurgery, defined as high-dose perfection conformal photon beam delivery in our institution, often given a 16 to 24 gray single fraction, or 24 to 30 gray in 3 fractions. And compared to conventional external beam radiation, the responses are both histology independent and ablative, and that fundamentally changed our indications for and type of surgery that we do. The decision-making with the integration of radiosurgery mandated that it become multimodality. At Memorial, we use the NOMS decision framework, where radiosurgery is fundamentally the most important for tumor control, and surgery largely now is an adjuvant to radiosurgery for decompression and stabilization. In the NOMS framework, there are 4 sentinel decision points: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. We're going to talk about the neurologic and oncologic indications principally today, and they are really a combination assessment. From a neurologic perspective, we're very concerned about whether the patient has myelopathy and functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression. There's a scoring system that's been validated where 0 is bone only, 1, A, B, and C are different degrees of epidural impingement without spinal cord compression, 2 is spinal cord compression but CSF seen, 3 spinal cord compression, no CSF seen. And for decision-making purposes, traditionally 2s and 3s have been considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control, which is completely predicated on the radiosensitivity of the tumor. Radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to radiosurgery. This is a paper by my great friend Peter Gersten, who's here today. But there was very little in the literature prior to this that looked at differential radiosensitivity based on tumor histology to conventional external beam radiation. But what's there was remarkably consistent. There are radiosensitive tumors, such as the hematologic malignancies, lymphoma, myeloma, and then the hormone-driven solid tumor malignancies, breast and prostate. The remainder of the solid tumors are largely radioresistant, with median durable responses of 3 months and 2-year local control rates of only 30%. There's only one series now that looks in the literature at comparing conventional external beam radiation to SBRT. This is Arjun Segal's Canadian prospective randomized trial. And the secondary analysis looked at local control with dose strategy in SBRT group of 24 gray and 2 versus conventional external beam 20 gray, and 5. And at every time point, SBRT had better local tumor control than conventional external beam radiation. And in a multivariate analysis, when you looked at epidural and paraspinal disease, that difference became even more pronounced. What's interesting in this group is that they considered almost 75% of their patients to have radiosensitive tumors. So if we only look at the radioresistant tumor histologies, we think these differences are significantly greater. We still use conventional external beam radiation. Here's a patient with multiple myeloma with very high-grade cord compression, Asia C, myelopathic, with 3-level epidural disease, high-grade cord compression. This patient got 30 gray and 10 on high-dose steroids, and you can see the 10-day follow-up film, the tumor completely apoptosed, decompressing the spinal cord, and recovering the patient to normal neurologic function. We also use conventional external beam radiation for high-grade cord compression with the hormone-driven solid tumor malignancies, breast and prostate. Here in a patient with a T3 with a grade 2 compression. The problem with breast and prostate is you're not going to get that apoptotic response to the tumor, so you're going to have this ongoing compression. In this case, it took us 4 months to decompress the spinal cord, and if you're myelopathic, you're not going to get recovery in that patient with radiation alone. And so in the myelopathic patients with hormone-driven breast and prostate, we do take them to surgery. But for most of the patients with the radioresistant tumors with minimal or no spinal cord compression, where we have a target, we go straight to stereotactic radiosurgery. Here's our series of a little over 800 tumors, principally with radioresistant tumor histologies, where again we had a definitive target for radiation with the SCC score 0 to 1C at a median follow-up of a little over 2.5 years. Contours were according to Radiosurgery Consortium guidelines. There were 2 dose cohorts defined. The median dose of the planning target volume in the low dose cohort was 16.4 gray single fraction versus the high dose group 22.4 gray. The only factor significant in its local failure was a dose of radiation, but even in the low dose cohort, 16.4 gray, we only had a 5% failure rate at a year, increasing to 20% at 4 years. In the high dose cohort, it was less than 1% at a year, increasing to only 2.1% at 4 years. We overcome radioresistance with high dose per fraction radiation, and these responses are both histology and volume independent. Much of the past decade has been used to define dose constraints for organs at risk. The most important is to the spinal cord, and at a cord Dmax of 14 gray, we have less than a 1% chance of creating myelitis. But it's that dose constraint that prevents us from treating high-grade cord compression, because either we'll give an ablative dose at the margin of the cord and create radiation myelitis, or we'll underdose at the margin of the cord and risk epidural progression where we need the greatest control. While we can't give single fraction radiation for high-grade cord compression, we had a number of patients that had significant contraindications to surgery, and so we started looking at hypofractionated radiation for grade 2 compression. In this series, all were radioresistant tumor histologies. They had SIN scores that put them in the potentially unstable category and were neurologically normal. The SBRT median dose was 27 gray and 3 fractions, with a median cord dose of 21.6 gray and 3 fractions. Local recurrence at 1 year was 10.4%, increasing to 22% at 2 years. The complications included radiation-associated fatigue, vertebral body fracture, and 2.5%, but there was no evidence of radiation-induced myelitis. So we're beginning to treat high-grade cord compression with hypofractionated radiation. We're improving the therapeutic window, right? We're going to give up a little bit of tumor control, but it's a very safe delivery, especially in patients who cannot undergo surgery. More recently, Chris Jackson and Dan Higginson looked at a larger series of patients, 2,700 lesions that we looked at with 3 fractionation schemes, 24 gray and 1, and then 27 to 30 gray and 3. We knew 24 gray single fraction would have a better local tumor control, but there was also a dose response in the hypofractionated regimen with 30 gray and 3 doing better than 27 gray and 3. And when we stratified by the spinal cord compression score in the hypofractionated groups, comparing 0 to 1C versus 2, 3, there is no difference in local tumor control. And so again, we're starting to treat more and more patients with high-grade cord compression, especially if they have significant contraindications to surgery with high-dose hypofractionated radiation, 27 to 30 gray and 3 fractions. We're also very interested in concurrent therapy, again, to improve the therapeutic index. We know that there's very good clinical and experimental evidence that VEGF-TKIs in combination with radiosurgery act as radiosensitizers. We like this concept of radiomodulation, the combination of stereotactic radiosurgery with superoxide dismutase mimetics, which improve our ability to give ablative radiation with the constraints of normal tissue tolerance. And then immune modulation, the combination of stereotactic radiosurgery with checkpoint inhibitors. Many of you know about the abscopal effect, where we give local radiation and get a systemic disease response, but it can also augment local tumor control at smaller doses or volumes treated. This is an example of a patient had a renal cell in the sacrum, twice irradiated and failed and progressed, had excruciating pain. They had skin changes from prior radiation, so they weren't willing to treat the entire volume, irradiate the entire tumor volume. And so Josh Yamada, my great partner, radiation partner, only gave the center core of that tumor 27 gray and 3. So 2/3 of that tumor essentially received no dose of radiation in combination with dual checkpoint inhibitors. By 1 month, you can see the necrosis in the tumor. By 2 months, the DCE image, looking at plasma volume, shows that the tumor is dead. The problem is, again, like that prostate cancer, you still can't get an immediate effective decompression of the epidural disease using any of these strategies, hypofractionated radiation or concurrent therapy. And so for most patients with high-grade cord compression with radioresistant tumors, we still go to surgery followed by radiosurgery. This is still largely predicated on the Patchell study, published in Lancet 2005. It was a prospective randomized trial of solid tumors with myelopathy, comparing surgery and conventional external beam to conventional external beam alone. And in every outcome variable, surgery was better than radiation alone. And based on that and a number of other studies, the Spine Oncology Study Group made a strong recommendation that patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression stabilization followed by radiation therapy. The question became what kind of surgery and what kind of radiation. With the integration of radiosurgery as a postoperative adjuvant, the surgical goals of spinal cord decompression for neurologic salvage and using screw rod systems to provide mechanical stability remain the same. What changed, right, is the oncology. How we achieve local tumor control, again, is completely predicated on the radiation response. So when we use conventional external beam radiation, it made sense to do maximally cytoreductive surgery, either gross total resection or even en bloc. With the integration of radiosurgery as a postoperative adjuvant, maybe the only goal has to be to reconstitute the thecal sac to create a better target for radiation. That became known as separation surgery. So here's an 86-year-old with papillary thyroid, Asia C, with 3-level vertebral body disease and high-grade cord compression. And I would submit to you that there is no way to get this patient through a 3-level front-back surgery. Separation surgery is a very straightforward technique that any surgeon in your institution can do well. Traditionally, we instrumented 2 levels above and below the index level. We take a high-speed drill, we drill off the lamina, superior and inferior facet joint, and pedicle flush to the vertebral body. We dissect the tumor off from normal dural planes, and then we resect the posterior longitudinal ligament to affect the margin on the anterior dura, and the entire procedure is done from a posterior-only approach. Instead of trying to take out all the tumor, the only goal of separation surgery, again, is to reconstitute the thecal sac to create a better target for radiation. Improvements to separation surgery for any of the surgeons in the room. Traditionally, we use minimum of 2 levels above and below the index level to distribute load and osteoporotic bone and prevent failure from adjacent segment progression. And that construct worked remarkably well with a fixation failure rate of only 2.8%. More recently, we've switched to short segment fixation, single level above and below the index level, using cement augmented fenestrated pedicle screws, and our fixation failure remains low at about 2.2%. And more recently, we're now going to more minimally invasive decompressive techniques to affect, again, this epidural decompression to make a target for radiation. In terms of performance status, 75% of our non-ambulatory patients regained the ability to walk with this technique, and overall 90% were ambulatory. In terms of patient-reported outcomes, patients did significantly well in terms of pain right now and general activity. In terms of local tumor control, if you did aggressive surgery followed by conventional external beam radiation, there's only one series in the literature that looked at those patients longitudinally. It was Claycamp Sammy, published a long time ago in 1998. But when they did aggressive surgery followed by conventional external beam radiation, their local control was only 30% at a year. And one of the biggest predictors of recurrence, right, was radioresistant tumor histology. So it didn't matter how aggressive you were taking tumor out. If you didn't give effective radiation, they're going to recur. Here's our initial series of separation surgery followed by radiosurgery in 186 patients. Most were operated for high-grade cord compression with radioresistant tumor histology. 50% had already failed prior radiation and were going for reirradiation after separation surgery. There were 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative of recurrence was 16%. But if we gave a high enough dose single or high dose hypofractionated radiation, there was less than 10% recurrence at a year. And again, there's no association with radio-resistant tumor histology. We overcome radio-resistance with high dose per fraction radiation. More recently, we've looked at histology-specific progression-free survival using separation surgery followed by a median dose of 8 to 10 grade times 3. For renal cell carcinoma, again considered very resistant to conventional external beam radiation, the 2-year progression-free survival was 92%, non-small cell lung cancer 95%, colon cancer a little less well at 87%. We looked at mutational status, and the patient had an EGFR mutation, was treatment naive. There was a 50% survival advantage. NOMS is ever evolving, and we always try to integrate evidence-based medicine and new technologies as they become meaningful. Today, in an algorithmic form, for radiosensitive tumors, regardless of degree of cord compression, we're still very comfortable treating with conventional external beam radiation. For radio-resistant tumors with minimal or no spinal cord compression, where you have a target for radiation, stereotactic radiosurgery is incredibly effective. For radio-resistant tumors with high-grade cord compression, traditionally we've gone to separation surgery followed by radiosurgery, but now for the patients who are not candidates for surgery, we are absolutely taking them for hypofractionated radiation, 8 to 10 grade times 3. We didn't talk about instability, fracture-related pain, but if a patient's unstable, they're often candidates for kyphovertebroplasty, perc screws, or open surgery, and then everything is predicated on what the patient can tolerate from a systemic disease standpoint. NOMS is a cornerstone for all of these large groups that are trying to coordinate comprehensive care in the modern management of metastases. It facilitates multidisciplinary clinical decisions that are made consistent, timely, and evidence-based, and we can integrate and develop meaningful technologies. And then for our group, it has allowed us to collaborate, create collaborative clinical and translational research. And you can see this group is really a very large effort at Memorial, and really the father of radiation oncology and the driving force for us has been Josh Yamada, who's been just a gift and a godsend in making this safer, better, and more effective. If anybody's interested in spine radiosurgery, there is just a huge amount of work left to do. We've had a really good run for almost 25 years now, but we're interested in a number of avenues of exploration, and we're happy to discuss that at some other point. But with that, I thank you for your attention.
Thank you so much, Mark. You know, what a great example of multidisciplinary medicine. With that, we have any Q&A from any of the audience. That would be great to ask questions. So go ahead, Dr. Fiveash.
This is John Fiveash from UAB. Dr. Bilski, I have a question for you. Could you speculate on why the RTOG 0631 trial was negative?
Which is the...
That's the 8 gray and 1 versus 16 or 18.
Yeah.
The doses were too low, and I think the endpoints were too short. So I think it was mostly, that was also a pain outcome study.
Pain
principally.
outcome as the primary endpoint at 3 months.
I think that we never really participated for the sole reason that 16 grade we thought was too low and probably wasn't going to be a significant difference. And at 3 months, conventional external beam radiation will often hold for a while, and then you're going to lose control. What we're really interested in are the really radio-resistant tumors and durable control, because so many patients are living longer. So I think it was just a poorly designed study that was done well before we had enough data to suggest what doses were going to be meaningful for that. And you know, I think Arjun's study was, again, a lot of radiosensitive tumors, but at every time point in that study they showed, you know, a significant difference. And he used, you know, a dose that's much closer to what we use at 24 and 2. I think 16 gray was just too low for a single fraction to be meaningful.
Thank you very much.
Thank you.
Other questions? Dr. Raju.
Roger Rowell from Ohio State University. Thank you. Great talks. For patients with large brain metastasis, we often try, unless we put them on BN12 for the clinical trial, we try to do preoperative fractionated radiosurgery for patients with large brain metastases that don't need to go to emergent surgery. You listed like a really nice new QA and workflow. How do you incorporate preoperative radiosurgery for large brain metastases patients?
It's a great question. Lots of emerging evidence. I think we are very aggressive surgically. If someone needs surgery, we really try and get them in, you know, within 2-3 days often. And so we haven't been doing too much of preoperative. curious to see what the data show. I know there's a lot of discussion, mostly centering on higher seeding rates than actually what we see clinically. We're seeing around the range of 5 or 10% for patients who really are living a very long time. In our workflow, it's been urgent. We've been kind of pressing on the urgency. As soon as someone is identified to need surgery, we kind of organize for everything to be done on the back end for radiation. But very curious to see what the data show.
Thank you.
Other questions? Going once? Well, if there are no other questions, we'll be happy to end the session. Thank you so much for our speakers. Excellent talks. And looking forward to seeing you in 2 years in another wonderful location.